Hello everyone, and thanks very much for joining us this evening. For those of you who don't know me, I'm Anna and I'm the Head of Support Services at Overcome. So just to say, please do get in touch with us if you have any questions after the webinar, but also if there's anything at all that we can help with at any point, or you just want to talk something through, have a chat, ask questions. If there's any information you need, there's myself, my colleagues Dora and Julia, and we're always really happy to hear from you. We can be contacted by phone, text, email, instant chat through our website, Skype or Zoom, and also through our online forum, My Overcome at Health Unlocked. So please do get in touch with us, and we're always really happy to hear from you. The other thing that we just want to say about the talk this evening is that there will be some footage of surgery taking place, which will include some images of internal organs. We will give you a warning just before those come up. So if you think that you would find that upsetting to see, then you'll have that advance warning and be able to, walk away from the laptop and come back and join us later. The other thing to say is as well that if you really don't want to risk seeing those images at all, that when we put this recording on our website, we will mark very clearly the timings of the video where those images come up. So that might be another option as well that possibly feels a bit safer, so that you don't see those images at all. But it will just be some close-ups of internal organs, so that Marielle can take you through a dye technique that they're using. And also if anyone has any queries about that or any worries, then please do get in touch with me, and I'll be happy to talk to you about it. So I'm delighted to welcome Ms Marielle Nobbenhuis, who's going to talk to us this evening about the role of robotic assisted surgery in ovarian cancer, and I'll hand over now.
Thank you, Anna, and thank you, Overcome, for inviting me to talk about this type of surgery. So I work at the Royal Marsden as a gynaecology surgeon, and I'm also a robotic surgeon. So I am teaching other gyneoncologists or gynecologists how to operate with the robot. So this is a little introduction to how robotic surgery works. And actually, I want you to just have a look at the preciseness of the robot. So you can see the surgeon in the left. So the surgeon is in control, and he has 3 little instruments he can work with. So there's a grasper, which holds, in this example, a grape, and then there are 2 scissors. So what the robot does, it's a tool. So it's never going to do anything on its own, but it's a tool to help us to work really, really precise. And you can see again here the surgeon completely in control, and what he's doing here is peeling off the skin of a grape. And you can see that's quite difficult to do that without a robot even, but this is how precise it is, and that's why I want to explain why we can use it in ovarian cancer surgery. So when we look at the progress in surgery over the years, and this is the last 200 years, we can see that the first laparotomy, which is an incision or cut in someone's tummy, was performed in 1807, and then there is an evolution of anesthesia. The first laparoscopic surgery, so the keyhole surgery, was performed in 1910, and only the first keyhole hysterectomy in 1989. So that took quite a while. And since 2005, we have the possibility to use the robot if we want to do minimally invasive surgery. So if you have surgery, there are 3 different options. The most common one is open surgery, where the surgeon makes an incision in your tummy, for instance, to look inside and remove, the tissue or the disease or the organs they need to remove. The other option is laparoscopic surgery. It's actually the same as keyhole surgery, where the surgeon makes little incisions in the abdominal wall, and through which go ports with little instruments, and with straight sticks or straight instruments, you can then look as a surgeon on a screen and then release the disease or the organs in someone's tummy, for instance. Robotic-assisted surgery is actually a little bit the same as laparoscopic surgery. It's only the addition is that we have a robot to help us to make it easier to operate minimally invasive or with the keyhole. And the robot, as I already said, will never be autonomous. So it is always a surgeon who has full control. And this is how, for instance, the robot looks like in our hospital. There are 3 different elements. One of them is what we call the patient cart. So this is attached to the patient's tummy. There are 4 little ports, about 8 millimeters in size. And we attach these to someone's tummy when they're asleep. And through all these ports go instruments. So a camera, a grasper, some scissors, sometimes an extra grasper. This is another console in the middle, which is there to sort of let the robot work. There's lots and lots of electronics in it, but also a screen you can see for the assistant, for instance, to see what's happening inside. And this is the surgeon's console. This is where the surgeon is sitting. It's in the same room where the patient is, but the surgeon is not sterile, so he's sitting there and he has possibility to look inside a screen and can see inside someone's abdomen, 3D, very precise, has joysticks to work with the instrument, and then foot pedals to increase the magnify the view or change between the different instruments. So this is what happens when you have surgery in the abdomen with the robot. You have 4 small robotic incisions and then another incision, which is for the assistant. The patient, of course, is fully under general anesthesia. We blow up the tummy with CO2, so it's easier for us to see the organs all differently. We then insert the ports, we dock then the robot. So you saw the robot with the arms, they will be docked to the patient. We will insert the instruments we need. We have various different graspers and scissors and other things we can use. And then if that's all done, the surgeon is then going to the console to work via the console in someone's abdomen. So with the patient is the anesthetist, is the scrub nurse, and is the assistant. So it's not that you're on your own. There's always someone immediately next to you, and the surgeon is sitting about a meter apart. So this is a little bit of a sort of an indication how that works. So this is our theater at the Marsden. Here you can see the console. This is where I sit. This is how the robot works. And here you can see how it's locked in. So what are the advantages of robotic surgery for the surgeons? First of all, the instruments have what we call 7 degrees of freedom, which means that if there are positions in someone's tummy, we can move it all the way 360 degrees. So we can go into different corners, very difficult corners, which we are not able to do with the traditional keyhole instruments. We can see everything 3D. We have 4 arms. So we've got a camera and 3 arms, and one of the arms can, for instance, hold something for a while, and then the other 2 arms work. There's control of the surgeon's the camera, so there's not an assistant who constantly needs to follow the surgeon, but the surgeon can just zoom in and out and go exactly to the place where he wants to operate. So there is increased precision, which you already saw with the little crepe video. It's easier for us. We sit in a console, so we don't stand for hours and hours, and there is no tremor. So especially when we operate in very delicate structures like near to the veins or arteries or the bowel, then there is no tremor and we can work really precisely. And what is really important is that it's easier for us to learn than the traditional keyhole operation. So what are the advantages for the patient to have surgery with a robot? So it's more precise. We know less blood loss. We know that there's a smaller risk that for some reason we can't do it all minimally invasive and we need to give you a cut. So that's what we call conversion rate is lower than in laparotomy. We know there is less postoperative pain, shorter hospital stay, and a quicker return to normal activity. So what is the difference between robot and the traditional keyhole or laparoscopic surgery? So what we know in robot surgery is that the learning curve for the surgeon is shorter. The ergonomics are better, so we're not standing for 4 hours hunched forward and look into a screen which is above our head. So it's much easier for us and much more relaxed for us to operate. We can see everything much better. There's no tremor. We know the outcomes are better, and it's easier to operate on patients, especially when patients are a little bit more obese. So when we look at the publications about robots, you can see that since the introduction, more than 7 million procedures have been performed with the robot worldwide, and more than 2,000 peer-reviewed articles have been published. And if we look at where we're talking about the Da Vinci, but there are other robots too. So when we look at the amount of robots, we can see that there are more than 5,500 robots now placed within the world. The majority in the States, nearly 1,000 in Europe, and also about 800 in Asia. And this is increasing and increasing. So what sort of operations are done with the robot? You can see different colors. Urology is light blue, this is general surgery, and the purple is gynecology. So what you can see is that there is definitely an enormous increase in the amount of gynecological robotic surgery. So what can we do with the robot? What sort of gynecology operations can we do? So the most common operation is the hysterectomy, sometimes with or without the ovaries and tubes. Another operation which is common with the robot is a tragelectomy. That's a kind of operation where you preserve the uterus, the womb, in cervical cancer, but you only remove the cervix. This is a very difficult operation, and it's much easier to do that with the robot. You can remove lymph nodes with the robot. In endometriosis, it's easier to operate. You can operate when there is a prolapse, for instance, when you have problems with urinary incontinence, when there's a fibroid, for staging an early stage ovarian cancer, which is what I'm going to focus on a little bit later, and also when there's recurrent cancer and you need bigger operations where you remove the recurrent disease, and sometimes with the bladder or a little bit of the bowel. We can do that with other specialties with the robot, which is far easier. So what we've noticed over the years is that the more expert we become in robots, the more suitability we see of the cases we can use for the robot. So in the Marsden, there are now currently 6 specialties who use the robot for surgery. Gynecology and urology are the biggest group, but also colorectal for instance, bowel cancer, head and neck for instance, tongue-based cancer, and the liver and the gastric cancer surgeons, sarcoma, and possibly plastics and thoracic in the future. But there's even a possibility that breast will start with robotic surgery. So it's a very common instrument we are using now. And we have 2 of these robots in our hospital. This is a picture of our team in 2007, when we performed the first robotic hysterectomy in the UK. That time was done by Professor Shepherd, who's now retired, and Thomas Ind. And then over the years, we first couple of weeks we operated on a significant amount of patients, and then we had a fire and we had to stop. The robot was luckily saved, but we had to put our program on hold, and we restarted in 2013 again, and we've done now more than 1,000 cases in gynae robotic surgery. So if we look at our experience in the hospital, what we can see is, if we look before and after the introduction of robot, we can see that before, there are about 60% of all our cancer cases operated on open, so with a laparotomy, and only 40%, a little bit less than 40%, minimally invasive, what we call straight stick laparoscopy. So after the introduction, you can see the purple is the robot. You can see that a lot of open cases suddenly became robotic cases. And this is the numbers we have looked at in 2016 after about 7 years of robotic surgery. But we can see that this is definitely now increased, with nearly 95% of all our cases minimally invasive, and more than half of them with the robot. So that has definitely changed the way we manage our cancer patients. And if we look at the advantages of the introduction of the robot, and then there's a lot of information on here, but I just want to let you know that if we look, for instance, at the blood loss, the open surgery, the laparotomies, have significant more on average blood loss than the robot. And if you look at, for instance, the conversions to laparotomy, then you can see that we didn't have any conversion in the early group of women, and about 18% in the women who had the traditional keyhole operation. So there definitely was a difference, what we identified. The other thing what we sometimes see is when you want to operate minimally invasive or keyhole, there are some risk factors which make it difficult to do that. For instance, a previous operations of scar tissue, or a big uterus, or what we call adhesions. So when your organs inside the bowels, for instance, are stuck together, or for instance, when you have problems with your lungs and it's difficult to ventilate. So what we could see is by starting with the robot, we could still operate also on these what we call relative contraindications. So that meant that where we would normally go to open, we were able now to operate on these women with the robot. So the robotic experience at the Marsden for us is that the introduction of robotic surgery resulted in a shift from open to robotic surgery with the same percentage of the laparoscopy. We had a significant reduction in length of stay. Our laparoscopy patients normally go home after 2 or 3 days, and the robot patients go home the next day. And I'm also going to talk a little bit about a dye we use with the robot. So it's not very easy to immediately start with a robotic program. So it's not that from one day to the next you can do immediately everything. So you have to have a very good team. And the team consists of the anesthetics team, the nursing staff, and the surgeons. And over time, we have changed the whole program of the robotic surgery. Initially, we send everybody to the intensive care for one night afterwards. But now we know that's definitely not necessary. And we even send the majority of patients home the next day because they're actually really well. They don't have any pain, they're able to mobilize. The other advantage we noticed is that there are not, what I already showed is there are what we normally think are contraindications to do an operation with the keyhole, like a large uterus or previous laparotomies or even an abdominal hernia. Nowadays are not for us contraindications, again, to do a robotic surgery. So now let's go to ovarian cancer. So I'm going to talk about staging in ovarian cancer. So staging in ovarian cancer is the procedure where you're either already diagnosed with cancer because you have had an ovary removed and that ovary came back as cancer, or we believe that you might have cancer because there is an abnormal ovary. And what we do then is do a staging operation where we want to find out if the cancer has spread. So traditionally, that is an operation where we do a midline laparotomy, so a cut up and down. We take some of the fluid, either ascites or what we call peritoneal fluid, where we just pour a little bit of water inside your tummy, take it out and bring it to the pathologist together with all the other organs we remove to see if there are any abnormal floating cells or cancer cells. We remove the womb, the uterus, the tubes, and the ovaries. Sometimes we remove the lymph nodes, so the ones near to the ovaries or the ones a little bit higher up. We remove the omentum, which is a fatty apron curtain hanging in your tummy, and sometimes we remove the appendix. But the whole idea of doing this kind of operation is that we're able to remove all visible abnormal disease. The disadvantages by doing it with a cut is that you need to stay in hospital for a longer time. It takes a longer time to recover, so 6 weeks at least, because you have an incision, and it's more expensive because you need more money for physio, for instance, pain medication. You will need to stay in CCU, that's standard of care in our hospital, for 1 night, and overall it has a lot of disadvantages. So if we can do this minimally invasive keyhole, that would definitely be so much better for patients. So minimally invasive, to make things complicated, I now mean either with the traditional laparoscopy or with the robot. And we can do this if we believe that the disease is early stage. So if we think, and we do normally scan, PET scan or CT scan before the operation, if we think that there is more disease than only disease involving the ovary, and it's difficult for us to get in all the different places in someone's tummy, then we would normally not recommend it. But if we think it's probably early stage, so only confined to the ovary, and we predict that by looking at the imaging, and we are able to oversee the whole abdominal cavity, then we would suggest for patients to have minimally invasive surgery to stage 4 ovarian cancer. And what are then the advantages using the robot versus the traditional keyhole operation is that we have less conversion to laparotomy, so we work more precise. We can go in different places. We can look around the corner, which is a little bit more difficult when you do it traditionally. Patients have less post-operative pain, and we know that the survival outcomes are exactly the same. So we don't compromise. So how do clinicians decide which route of surgery is the best? So what I already said is, of course, there will always be a discussion with the patient and the family. So it's important that we explain what the several options are and why we would decide either to do a laparotomy or a minimally invasive robotic surgery. So it all depends on the disease. If we think it is not a lot of disease we need to remove and it's easy for us to get access to that, then we would recommend normally minimally invasive robotic staging. Sometimes patients have what we call comorbidities when it's a little bit more complicated to do this. For instance, their weight is a little bit high, or they have problems with their lungs. And as you can see, when we do robotic surgery, we blow up someone's tummy to make sure that we can see all the different organs. You always go a little bit head down on the table, and that is just to make sure that the bowels flop into the upper abdomen, and that sometimes makes it a little bit more difficult to ventilate the lungs. So if there are women with a lot of lung problems, COPD or asthma, sometimes we can't do it minimally invasive. If you have a lot of previous scars, we can start with minimally invasive surgery, but sometimes we will know that it's a little bit too difficult because we can't see all the different areas inside someone's tummy, and then we need to stop doing it and give you a cut. The other reason, which is why it's important to sometimes decide to do a minimally invasive robotic surgery, is if we want to try to do fertility sparing surgery in ovarian cancer, because then your risk of scarring is less. So now I would like to talk about a typical patient we normally see who will very likely have robotic staging surgery for ovarian cancer. It's normally a relatively young patient who, for instance, this is a 24-year-old patient who has had her left ovary removed in a smaller hospital, unit hospital, because they thought it was a cyst which looked slightly abnormal, and then unfortunately that came back as cancer, completely unpredicted. So she then will be discussed in our Gynaecology Center meeting, MDT. And we will then decide, well, we need to operate to see if it has spread. So we need to organize, we call it staging procedure. So we see the patient in the clinic. We will organize a preoperative CT scan, sometimes also an MRI scan. And if there is no abnormality in the remaining ovary and no obvious peritoneal disease, then we would potentially offer robotic staging. In this case, a 24-year-old patient, we will always discuss fertility sparing surgery, and I will come back to that in the next slide. So in her case, we've offered her a robotic-assisted ovarian staging procedure. So that means that she comes in the day of surgery. The operation takes about 4 hours. We will do exactly the same as what we would do in open surgery, and she goes home the next day. So when can we do fertility sparing surgery in early stage ovarian cancer? We can do that if we think that the cancer is early stage. So when it's confined to one ovary only. Of course, you will not know for sure unless you've done your operation, but this is a prediction after looking at the preoperative scans. And what it involves, fertility sparing surgery, is that you preserve the womb, the uterus and the other ovary. It's very important that during the operation, you assess the remaining ovary, so the ovary which doesn't have the cancer, and that you take some biopsies to make sure that it's normal. Fertility sparing surgery is not really possible if there is too much disease. Then we can't offer that because it's too risky. And if we plan for fertility sparing surgery, we will always refer patients to fertility specialists to see if we can't do fertility sparing surgery, we will always refer patients to a fertility specialist to see if we can preserve eggs, or if we can preserve from ovarian tissue, or if we can do IVF before the operation and store the embryos. So this is a very important, especially in young patients, a very important subject we will always discuss. And sometimes it means the patients come back several times to discuss and to be prepared for the surgery. So this is an image about lymphedema. So you can see a lady with a normal leg and a little bit swollen leg, and that's what we call lymphedema. So in gynae cancer, we used to take lymph nodes. So lymph nodes are the glands which are, we have thousands of glands inside our body, and lymphatic glands are important because they deal with fighting disease, fighting an infection. And sometimes in cancer, the lymphatic glands can contain cancer cells. So it is important to sample them, or to at least have a clue if they contain cancer cells, because that means that you might need to have further treatment. So we do this in ovarian cancer. So we do this in cancer, gynae cancer, a lot. But we also know that it's not always necessary to take lots of the glands. For instance, here you can see the uterus here with the ovary, and these are the big arteries and the veins in someone's abdomen, and alongside these arteries and veins, we find the lymph glands. They are not like just separate nodules. They look like fat tissue. Sometimes difficult to really distinguish between fat and lymph glands, but these are the ones we're very interested in gynae cancer. We know that in a lot of women, they are negative, and we don't really need to remove them. So what we've decided, there's a lot of research currently going on, and also in the past, where we could try and see if we can find the sentinel lymph node. So the sentinel lymph node is the first lymph gland, it's lymph node, which is draining from an affected organ. So that can be a lymph gland from the cervix, or a lymph gland from the uterus, or a lymph gland from the ovary. And if we can identify that first lymph node which drains from the affected organ, what we call the sentinel lymph node, then we can probably omit all the other lymph node removals and avoid lymphedema. So what it means is, how can we find these sentinel lymph nodes? So in robotic surgery, we find them by injecting a green dye in the affected organ, or the blood supply to the organ. For instance, in cervical cancer, we inject the cervix while you're asleep, just before the operation. And that dye, we call it indocyanine green. The dye will then be taken over into the lymphatic channel, and we can see that by using a filter on the robot. And we can see the lymphatic pathway through as a green pathway. So we use this in cervical cancer and endometrial cancer, but we are also doing a lot of research now to see if we can use this dye also in ovarian cancer. So for instance, is there a possibility that we can try and find that sentinel lymph node in ovarian cancer? And currently there is some research going on where we inject the blood supply to the ovary with this dye and see if we can identify where the lymph nodes are. So hopefully in the future that would mean that we can just avoid too much lymph nodes to be removed and identify only the ones we're really interested in. The other research currently with the green dye, the ICG, is try and identify whether we can see little deposits of cancer in someone's abdomen, which will then also be green if we put the filter on. So this is a graphic in video, and I will just show it for 10 seconds, where I just want to indicate how that looks like. So this is a view from the surgeon looking inside someone's tummy. You see the uterus here. You see one of the graspers we use. You can see it's all very magnified. And what we've done is this lady injected the cervix with the green dye. And we're now going to try and find where the dye is going to go to. So we're trying to find, here you can see the tube, and here you can see the dye. You see, you can follow the whole dye until it sort of ends here, which is probably where we think the sentinel lymph node is. And this is what we can separately take and send for the pathologist to have a look at. So this is the end of my presentation. Thank you very much for your attention. I don't know if there are any questions, but I hope it was a little bit clearer now what it means if you have robotic surgery.
Thanks ever so much, Marielle. So we've got a question come in. What information do you give to the patient so they can make an informed choice about their treatment option?
So we explain all the different options. We explain, the traditional laparotomy, the robot or the traditional keyhole, and the advantages. And patient can decide what they want to, what they don't want to do. It is very rare that a patient say, "Well, give me a big cut." And lots of patients say, I really would like to be back to normal activity. Some patients find it difficult to understand how a robot works, so they think it's an autonomous instrument which will just, you press a button and it starts, and it, but it is completely not. It's just a tool we use, and I hope I made it clear also in this presentation that it's a tool we use to make it easier for us.
Yeah. Thank you. If anyone's got any other questions, do drop them into the chat or the Q&A. And I was wondering about the sort of visuals that you have while you're doing the surgery, because obviously you're away from the patient, but at the same time you've got the monitor. So actually, are the visuals better, or how do you?
Much better. So you can, first of all, you see everything 3D. It feels like you're in someone's abdomen. It's funny, but it feels like you're completely on top of the tissue, and you can magnify. So you can work really, really precise. So I'm still very much in contact with the anesthetist and the assistants and the scrub nurse. So there is an so that we can still talk to each other. So it's not that I'm completely involved, but it is just much easier for me to do this kind of operation. Yeah.
And another question's come in: is robotic surgery used for interval debulking surgery?
So that's also part of research. So it's not standard of care now. Minimally invasive surgery, like traditional laparoscopy, is not really standard of care doing interval surgery, debulking surgery, but we are looking at it. especially when we believe that there has been a very good response to chemo, for instance, and there is not a lot of residual disease what we need to remove. We're looking at the option to then use the robot to do that operation. Yeah.
Another question, as well as having benefits to the patient, how much cheaper per operation is using robotic surgery?
So a robot is not very cheap. So when we compare the outcome of the patient, I'm thinking about the admission in the hospital, the length of stay. If you compare a laparotomy versus a robot, then it's cheaper because, of course, 7 days in hospital versus 1 is significantly shorter. But the operation is definitely not cheaper than a laparotomy. Yeah.
And someone's asked, is robotic surgery available throughout the UK?
Not in all gynae centers there is robotic surgery, so there's still a possibility just to have a traditional keyhole operation, and there are a lot of centers which have very, very good experience and very good expertise in doing keyhole, but it is increasing, and I would think in the next 5 to 10 years we will see that there is more. That there will be more possibilities to have robotic surgery, but it is not available for everyone. Yeah.
And so following on from that, someone's asked how many hospitals in the UK have access to robotic surgery?
So about more than 100 hospitals. Some of them only do urology, or they do everything gynae urology, but more than 100.
And someone's asked, how can we raise awareness amongst the public of robotic assisted surgery and benefits to patients?
Well, by doing a presentation like this, for instance. So so that's why I'm very happy that I'm able to present our data. And we try to do a lot. We have a British and Irish Gynae Cancer Society called the BIARCS. So you can have a look at that website. And there's some patient information on it too. It's just in development, so the plan will be in the future that you are able to see which gynecologists are able to do robotic surgery, and see if there's a center nearby. Yeah.
Someone's asked, are there any disadvantages with robotic surgery?
So the current disadvantage, I think, is that it's still expensive. A robot is expensive. What we know is the more robotic surgery you do within a hospital, the cheaper it gets. So for instance, in our hospital, we operate nearly 6 days with the robot, with the different specialties. So overall per procedure, it becomes cheaper, and also the initial costs to buy a robot is then eventually cheaper. And that's what we also recommend for centers when they start robotic surgeries, that please work together with other specialties. So it's not in the corner of the theater and only used for 1 day a week, but you really need to work together in order to make it cost effective. Yeah.
Great. Any other questions from anyone, please do pop them in the Q&A in the chat. So if for surgeons training and things, how long does it take to train someone in robotic surgery?
So the majority of, or actually everyone who will want to start as a robotic surgeon will be a consultant already. So they will be trained being a gynecologist or a gyneoncologist. And part of our training is minimally invasive surgery anyway. So we just need to convert from the traditional laparoscopy to learn how to use the robots. So that's a very intense process. So it's not that we just start immediately on patients. First, you need to do a computer, you need to go through a computer program and learn how the robot works. Then you have to observe, then you go to some labs. You will practice on on sort of dry labs. And then if we believe you're ready for it, one of us, a proctor, will come and be with you for the next 5 to 10, 15 cases to guide you. before you're able to do it on your own. So it's not very simple to buy one and do it. That's not how it works.
Yeah. And just while I was asking that question, someone asked how much extra training is needed. So I hope that answered your question. But if there's something else you'd like to know about training, then do let me know. Someone has said, how much does a robot cost?
Well, that depends what you want to buy, but it's about in the 2.5 million. Yeah, depends on what sort of robots you want to buy. There are different kinds. We're developing different ones. But I always say it looks expensive. However, the traditional keyhole operations are done also in what we call OR1s. So these are adjusted theaters with lots of screens and extra instruments. So that's also not very expensive, not very cheap. So it's not that it's nothing against a lot. And I think you have to see it in the perspective. Yeah.
And someone's asked, in the future, do you see RAS, MIS centres of excellence?
Potentially, yes. There are already some robotic centres of excellence, which are the centres who are doing a broad, who are have expertise in a broad amount of different gynae cancer, for instance, or different other surgical procedures with the robot, and that will definitely happen, I would think. Yeah.
And where does the sort of UK's use of robotic surgery, where does that stand in comparison to other countries? Do other countries sort of use it more, or have less of a tradition of doing robotic surgery?
So I think the States is definitely the leader with robotic surgery, but within Europe, and we work very close together with our European robotic surgeons. So we have meetings every year. I think the UK is one of the front runners in the amount of robotic surgery we do. Yeah.
Okay. Any more questions from anyone? Anything that you'd like to ask? And is it used? We certainly have a lot of interest from our members in secondary surgery for recurrence of ovarian cancer. Is the robot used for that at all?
So potentially there might be a role if we know it's a single site of recurrence and it's easy to remove. So where you traditionally do a laparotomy because you're able to feel all the structures, with robot it's a little bit more complicated because you need to make sure that you have access to all 4 quadrants of the abdomen. So when women have had extensive surgery in the past and everything's stuck together, then it becomes a little bit more complicated to do with the robot. But if there's one easy accessible recurrence, it's one side, there might be a role for robotic surgery. Yeah.
And someone's asked, do gynaecologists around the UK know about the advantages of robotic cancer surgery, and can patients be referred for robotic surgery from other hospitals?
Well, they know about the advantages because we are an affiliated society with the Royal College, so we present in all the gynae and general gynae and gynaecology different courses. Now it's not really possible to be referred for robotic surgery because we don't have the capacity, unfortunately. But as I already said, there is still a possibility to also have minimally invasive surgery, like with a traditional keyhole operation, and that might be a possibility if you don't have access to the robot. But now at this current timing, especially since with COVID, it's just really impossible to take over all the patients we want to, unfortunately.
Thank you. Any other questions from anybody? Give it just a few minutes, and then if there's no more questions, we'll tie up. I'll just check I haven't missed any in the chat. No. Okay, that seems to be the end of the questions. So thank you very much for such an interesting talk, Marielle, and we've really enjoyed it. Alice, do you want to say anything about the recording and things, or is there anything else that you want to add, Ms Nobbenhuis, about anything before we finish?
No, I hope everybody enjoyed it, and please have a look at our website, www.biax.org.uk. I should have written it down, if you want to have a little bit more information. Yeah.
Oh, someone said, what was the www you mentioned, which will list the consultants who can do robotic surgery?
Yes, that's going to be the future. Our society just we just developed a new website, and the plan will be that hopefully within a year or so we have all the available gynecologists on that website who are able to do robotic surgery.
Great.